Chapter 19, Supply Chain Management within the Sterile Processing Department. Welcome to Chapter 19. We will now explore supply chain management within the Sterile Processing Department. This chapter shifts our focus from the technical aspects of cleaning and sterilization to the logistical and financial backbone of the hospital. We will begin with the introduction and the fundamental definitions of inventory. Supply chain management is a broad term that encompasses the procurement, storage, inventory control, and distribution of materials. The Sterile Processing Department acts as a critical hub in this chain. You must understand the gravity of this role because the consequences of failure are immediate. If the right supply is not available at the right time, the surgery cannot proceed, regardless of how sterile the instruments are or how skilled the surgeon is. A missing item is a cancelled procedure. We must first define exactly what we mean by the term inventory. In the context of sterile processing, inventory refers to both the reusable equipment and the consumable supplies used to provide patient care. Collectively, this inventory represents a massive financial investment for the hospital facility. The sterile processing technician serves as the guardian of these assets to prevent waste, loss, and damage. We categorize inventory into two distinct groups. The first group is reusable inventory. These are items with a higher cost and a long lifespan. Examples include surgical instruments, stainless steel basins, intravenous pumps, and transport carts. These items are assets that remain in circulation for years. The second group is consumable inventory, often referred to as disposable inventory. These are items intended for single use or limited use. Examples include detergents, sterilization wraps, chemical indicators, needles, and catheters. Once these items are used, they are discarded and must be replaced. Next, we must address the question, where does inventory come from? While many items are purchased directly by the hospital and stored in a warehouse, some expensive items are managed through a specific financial arrangement known as consignment. This is a critical concept for your professional knowledge and your exam. Consignment inventory is defined as items that are physically stored at the healthcare facility but remain the property of the vendor until they are actually used. The billing trigger here is the key operational difference. The hospital is not billed for the item until it is opened or consumed during a procedure. A common example of consignment inventory includes implantable devices, such as screws, plates, and total joint replacements. The reason facilities utilize the consignment model is primarily financial. It is often too expensive for a hospital to purchase every possible size of screw or plate upfront and let them sit on a shelf. Consignment allows the facility to have the complete stock on hand for the surgeon to choose from without incurring the upfront cost of owning the inventory. The facility only pays for the specific screw that is implanted into the patient. Having established the sources of our inventory, we now turn our attention to the specific handling requirements for commercially sterilized items. Not all items used in surgery are processed within the hospital. A significant portion of your inventory arrives pre-sterilized directly from manufacturers. These items include sutures, sponges, disposable drapes, and various single-use instruments. Because these items are classified as medical devices, they are strictly regulated by the U.S. Food and Drug Administration, FDA. As a sterile processing technician, you must be proficient in identifying and interpreting the packaging symbols mandated by manufacturers. The symbol indicating that an item is sterile is typically a square containing the word sterile. It is equally important to recognize the symbol for "Do Not Reuse," which classifies an item as single-use. This symbol is depicted as the number 2 inside a circle with a diagonal slash through it. When you see this symbol, the item must be discarded after a single use and cannot be reprocessed. A critical distinction exists regarding expiration dates. While items sterilized in-house often follow the principle of event-related sterility, where the item remains sterile until an event compromises the package, commercially sterilized items typically carry a specific hard expiration date determined by the manufacturer. This rule is strictly enforced. You must adhere to the printed expiration date on the package. If a commercial item has passed this date, it must be discarded or returned to the vendor. It cannot be re-sterilized in-house unless the written instructions for use, IFU, specifically allow it, which is an extremely rare occurrence. The inspection protocols for these commercial items are rigorous. Before you dispense any commercial item to the operating room, or a nursing unit, you must inspect the integrity of the package. You are looking for physical damage, such as tears or punctures in the wrapper, water stains that indicate potential contamination, or crushed boxes that may have compromised the product inside. If any of these defects are found, the item is considered unsafe and must not be used. This leads us to the breakout protocol. Commercial items arrive at the hospital in large external shipping containers, usually made of corrugated cardboard. These containers must be removed in a designated breakout area before the supplies are moved into the sterile storage area or the clean core. This protocol is enforced to prevent environmental contamination. Corrugated cardboard is known to harbor dust, insects, and bacteria picked up during transport on delivery trucks. Therefore, corrugated cardboard is strictly prohibited in the sterile storage area, and it must never be placed on the same transport cart as sterile items entering clean areas. Additionally, we must ensure environmental safety during receipt. Supplies should never be left on loading docks where they are exposed to extreme temperatures or humidity, as this can degrade the product or the sterile barrier before it even enters the inventory system. Finally, we must discuss the Unique Device Identifier, or UDI system. The UDI is a system established by the FDA to adequately identify medical devices throughout their distribution and use. The primary purpose of this system is to improve patient safety by enabling faster and more accurate tracking of recalled devices and improving the reporting of adverse events. The UDI code on the package allows a specific item to be tracked from the manufacturer all the way to the specific patient who received it. The UDI code typically identifies 4 specific data points that you should know. 1. The device model or version. 2. The specific lot number of the batch. 3. The expiration date. 4. The manufacturer. In many modern facilities, sterile processing technicians are required to scan this UDI barcode into the instrument tracking system during tray assembly, ensuring a complete digital history of the device. With the items properly received and inspected, we now face the logistical challenge of organizing and distributing them efficiently. In a large sterile processing department, SPD, that manages thousands of unique items, relying on memory to find supplies is a recipe for errors and delays. Therefore, facilities utilize specific item locator systems to direct staff to the exact location of an item. These systems range from simple alphanumeric shelf labels to complex computerized databases utilizing barcodes or RFID, radio frequency identification, technology, but the underlying concept remains the same. For the exam, you should understand the concept of the 3-part address system. Much like a street address guides a mail carrier to a specific house, inventory locations are often assigned an alphanumeric code representing 3 specific coordinates. 1. The shelf, indicating which vertical shelving unit the item is on. 2. The level, indicating the specific shelf height from the floor. 3. The bin, indicating the specific box or container holding the item. The goal of this system is to enable any technician, even a new hire, to find any item immediately, improving efficiency and reducing the time spent hunting for supplies. Now we move to the core operational component of this chapter, which is inventory distribution systems. You must be able to distinguish between the 5 primary methods used in healthcare based on their operational definitions. The first method is the par level system, also known as periodic automatic replenishment. In this system, a standard supply level, known as the par, is established for each item in a specific department. The process is straightforward. Staff count what is currently on the shelf and order only enough to return the stock to that predetermined level. For example, if the par level for a specific bandage is 10 and there are currently 4 on the shelf, the technician will order 6 to bring the count back up to 10. The key phrases to remember for this system are predetermined level and reorder point. The second method is the exchange cart system. By definition, this inventory system uses 2 identical carts containing the same supplies. The process works by rotation. One cart is placed on the nursing unit for use, while the second cart is kept in the sterile processing department or distribution area. At a scheduled time, usually daily, the fully stocked cart from SPD replaces the used cart on the unit. The used cart is then taken back to be replenished. The primary benefit of this system is that it reduces the need for nursing staff to count supplies or order items manually, allowing them to focus entirely on patient care. The third method is the requisition system. This is a reactive method where items are requested by the user department on an as-needed basis. In this process, the user, such as a nurse, fills out a form or enters a digital request, and SPD staff pick the item and deliver it. While simple, this system has significant disadvantages. It is often inefficient and tends to promote hoarding by nursing staff who fear they will not get supplies quickly enough when they need them. The fourth method is the case cart system, which is the gold standard for the operating room. This is an inventory control system where supplies and instruments are gathered for a specific surgical procedure. The process begins with a preference card, or pick list, which details exactly what the surgeon needs for a specific case. SP staff pick the disposable supplies and instrument trays, load them into an enclosed cart, and deliver it to the OR. After the surgery, the dirty instruments are placed back in the cart, and the closed cart is returned to the decontamination area, creating a secure, closed-loop system. The fifth and final method is the just-in-time, or JIT system. This is an inventory strategy where minimal stock is kept on site. Instead of storing boxes of supplies in the hospital warehouse, supplies are delivered by the vendor immediately before they are required. The goal of just-in-time is to minimize inventory costs and strictly limit the amount of storage space needed within the facility. Now that we understand how inventory is physically distributed, we must examine the specific responsibilities you hold in managing these assets. The sterile processing technician is not merely a cleaner or a packer, you are a financial guardian. Every item you handle, from the smallest needle to the most complex robot, has a cost attached to it. How you handle these items directly impacts the bottom line of the hospital. We often refer to the loss of inventory in the healthcare industry as shrinkage. Shrinkage is a significant problem that occurs due to 4 main factors that you must be able to identify. The first, and perhaps most frustrating factor, is hoarding. This happens when nursing or medical staff hide supplies in unauthorized drawers or lockers because they do not trust the replenishment system. While their intention may be to ensure they have supplies for their patients, hoarding makes those items invisible to the inventory system, causing unnecessary reordering and waste. The second factor is expiration. This is largely a failure of process, specifically poor stock rotation. If staff fail to use the first in, first out FIFO method, older items are pushed to the back of the shelf where they sit until they expire. Once expired, these items are a total financial loss. The third factor is damage. This is often caused by improper handling within the sterile processing department itself. Common examples include dropping sterile packs on the floor, stacking heavy instrument trays on top of delicate peel pouches, or handling wet packs. If an item is damaged, it must be discarded and replaced, increasing costs. The fourth factor is theft. While less common than the others, the unauthorized removal of hospital supplies for personal use contributes to overall shrinkage. To combat these losses, technicians play a vital role in inventory reduction. Keeping too much stock on the shelf leads to a condition known as obsolescence. This occurs when items sit on the shelf for so long that they become outdated, or the technology changes, rendering them useless before they can ever be used. You help identify these slow-moving items so they can be removed from inventory, freeing up space and capital. Additionally, you may assist in standardization, which involves working with the surgical team to reduce the variety of similar items, for example, stocking one type of bandage instead of 5 different brands, to further reduce inventory costs. Accuracy in your daily tasks is also paramount to preventing supply chain failure. When you are restocking a cart or assembling a surgical tray, you must record the usage of consumable items precisely. For example, if a technician uses 5 filters for a container but only records the use of 1 in the computer system, the inventory software will not know to reorder the missing filters. This leads to stockouts. A stockout is defined as running out of a critical item when it is needed. In a surgical setting, a stockout is not just an inconvenience, it can cause dangerous delays in patient care. Finally, we must address the loss of sterile items during transport. This is a specific category of loss that involves the physical movement of goods. If a sterile tray falls off a transport cart due to careless loading, or if a wrapper is torn during transit to the operating room, the item is no longer sterile. It cannot be used, and the hospital has lost the value of the labor and supplies used to process it. Secure transport is, therefore, a financial responsibility as well as a safety one. To prevent this, transport carts should ideally have solid bottoms to protect the supplies on the lower shelves from environmental contamination that splashes up from the floor. To effectively manage the inventory and minimize financial loss, we must also understand how the hospital classifies these items for accounting purposes. In the eyes of the hospital finance department, not all inventory is created equal. We divide inventory into 2 primary financial categories: capital equipment and expendable inventory. Capital equipment refers to items that are relatively expensive and have a long life expectancy, usually remaining in service for multiple years. Because of their high value, hospitals often set a specific dollar threshold to define an item as capital. For example, a facility might decide that any item costing more than $1,000 or $5,000 is considered a capital asset. Common examples in our department include steam sterilizers, automated washer disinfectors, operating tables, and robotic surgical systems. Because these items are depreciated over time for tax purposes, they are tracked differently than bandages or soap. You can identify capital equipment because it will typically bear a specific asset tag, often a metal plate or a permanent sticker with a barcode that is distinct from the manufacturer's label. In contrast, expendable or consumable inventory refers to items of lower value that are consumed or used up during the course of patient care. Examples include sutures, needles, sterilization wraps, and detergents. These items are purchased, used once or a few times, and then discarded. They are considered an operational expense rather than a long-term asset. Maintaining accurate counts of both capital and expendable items is a constant challenge. We face a common problem where the quantity listed in the computer system disagrees with what is physically sitting on the shelf. This discrepancy is usually due to logging errors or misplacement of items. To solve this, facilities employ a process called cycle counting. Cycle counting is defined as a continuous inventory audit process. Instead of shutting down the entire department once a year to count every single item in the building, a process known as a total physical inventory, which causes massive disruption, cycle counting breaks the task into manageable pieces. A small subset of inventory is counted on a specific day on a rotating schedule. For example, staff might count aisle 1 on Monday, aisle 2 on Tuesday, and aisle 3 on Wednesday. This allows the department to verify its inventory accuracy continuously throughout the year without ever stopping operations. The goal is to identify and fix discrepancies immediately, ensuring that when a surgeon needs an item, the computer correctly says it is available. Ensuring the accuracy of our counts is only half the battle. We must also ensure the quality of the items sitting on those shelves through proper stock rotation. This brings us to a fundamental concept in inventory management known as FIFO, which stands for first in, first out. The logic of FIFO is simple but critical for patient safety. When new supplies arrive from the vendor or the sterilizer, they should never be placed in front of or on top of the existing stock. Doing so pushes the older items further back where they may be forgotten. Instead, you must physically move the older items to the front and place the newly received items behind them. This ensures that the oldest item on the shelf is always the next one to be used, preventing items from sitting for extended periods. You might ask why stock rotation is necessary if many modern items do not have a printed expiration date. This leads us to the concept of event-related sterility. In the past, hospitals used time-related expiration, where every sterile pack expired after a set number of days, such as 30 days. Today, we operate under the principle that sterility is event-related, not time-related. This means that an item remains sterile indefinitely until a specific event compromises the package. Such events include moisture, tears, punctures, or broken seals. However, relying on event-related sterility does not mean items have an infinite shelf life in practice. This is why we still rotate stock. Even if an item does not strictly expire, the packaging materials degrade over time. Blue wrap can become brittle, plastic fronts on peel pouches can separate, and dust can accumulate on the surface. By moving older stock to the front, we ensure that items are used while their packaging is still strong and intact. We are preventing the event of packaging failure caused by age and neglect. Therefore, effective stock rotation is a proactive safety measure that protects the sterile barrier. As we consider the life cycle of our inventory, we must finally address the environmental impact of what we do. The Sterile Processing Department is one of the largest generators of waste within the hospital, particularly when it comes to disposable packaging. A significant portion of this waste comes from the blue sterilization wrap used to package instrument trays. To address this, facilities are increasingly adopting sustainability and green initiatives. One of the primary methods used is recycling. The blue sterilization wrap commonly used in hospitals is made of a plastic material called non-woven polypropylene. While this material is recyclable, the process comes with a very specific and strict catch that you must know. Blue wrap can usually only be recycled if it is clean, dry, and collected before the surgical procedure begins. This is known as the pre-incision rule. It means that the wrap must be removed from the tray and placed in a dedicated recycling bag before the first incision is made on the patient. Once the surgery starts and biohazardous fluids are present in the room, the wrap is considered potentially contaminated. If the wrap has any blood or body fluids on it, or if it was removed after the case began, it cannot be recycled and must be thrown in the trash. This requires strict discipline from the operating room staff to segregate the waste correctly. Another powerful method for improving sustainability is the use of reusable rigid containers. Instead of wrapping every tray in a new sheet of disposable blue paper which is thrown away after every single use, facilities use metal or plastic containers that can be washed and reused thousands of times. By switching to rigid containers, the department significantly reduces the volume of waste sent to landfills and lowers the cost of purchasing disposable wraps over time. This approach aligns financial responsibility with environmental stewardship, ensuring that we protect the planet while we protect our patients. Having covered the entire life cycle of supplies, from procurement to disposal, we have arrived at the conclusion of Chapter 19, Supply Chain Management. Throughout this chapter, we have established that the Sterile Processing Department is far more than just a cleaning service. It is the logistical heart of the hospital. We began by defining inventory, separating high-value capital equipment from daily expendable supplies, and we learned how consignment allows facilities to access expensive implants without the upfront cost. We navigated the complexities of distribution systems, contrasting the automatic nature of par levels and exchange carts with the surgical precision of the case cart system. We also faced the realities of shrinkage, understanding that hoarding, expiration, damage, and theft are not just administrative problems but direct threats to the hospital's ability to function. We emphasized your role as a financial guardian, protecting these assets through accurate cycle counting and strict adherence to expiration dates. Finally, we look to the future through sustainability, realizing that our choices in recycling and the use of reusable rigid containers have a lasting impact on our environment. The bottom line of supply chain management is simple yet profound. Your goal is to ensure that the surgeon has exactly what they need, when they need it, in the most cost-effective manner possible. Without the correct supply, the most skilled surgeon is helpless, and the patient cannot be treated. As a sterile processing technician, you carry the responsibility of ensuring that the chain remains unbroken. This concludes our study of Chapter 19, Supply Chain Management within the Sterile Processing Department.